Welcome to this week's edition of the Belau Report. I'm Jane Belau. Our guests this week were honored with the presence of Kathleen Harrington, who is the Division Chair for Policy and Government Relations at the Mayo Clinic. And we're glad you're here.
Well, thank you, Jane. It's nice to be with you.
It's probably been about, I think, the fourth time you've been on the program.
Yes, I'm a very lucky girl.
Oh, it's a pleasure to have you back, especially since we've been doing programs that relate not only to national politics, but also health care. It's such a crisis in Minnesota, and everybody's got an idea how to fix it, including some campaigns who campaigned against Obamacare and want to repeal it, but nobody really knows what to put in its place. And first I'm going to ask you, were you surprised by the elections?
I think I definitely was surprised, Jane, and I'm certainly not unique in that. All of the pundits were very surprised. But it's very interesting when you talk to people now, and those who are willing to admit they voted for Donald Trump, and the reasons why. I think this was an election very much about change, and as we probably should have reflected more on that from the beginning of the election cycle, but it clearly, I think, is a statement about change.
Okay, do you think it's going to happen? Because in the first week, it sounds like there's a lot of softening of these positions from the president-elect, but maybe that's not how it'll turn out.
Well, I have confidence, Jane, that there will be change. I think there will be change in healthcare policy. I think we've learned a lot over the past 6 and 7 years about some of the foundational elements that were incorrect and redounded to the problems we face today. But these are fixable. I can tell you, our CEO has said, and our message to the transition team is that we urge them to take a surgical approach to reviewing the ACA. A really laser-focused review, focused repeal, and repair. Let's get away from the polemics of the conversation and really get to the substance.
And I know you know Tim Penny, former congressman, who's out in Washington as we speak with the Committee for a Responsible Federal Budget. And he knows a lot about Obamacare and about the Social Security Administration. And he said from the beginning they were going to have trouble with Obamacare because it made so many assumptions, like well people under 30 joining up, but the penalty for not joining up was so much less than the premiums that everybody's just paying the penalty. So they don't have enough money to take care of the program.
Well, they don't, and I think there's some other very fundamental mistakes that were made. And you know, hindsight's brilliant, and in this case, it is exceedingly brilliant. But when you look at the foundations of the insurance principles here, where how they determined how they're going to measure risk. They really did that in a way that it was not correctly adjusted for the types of people who are purchasing individual insurance. In general, they're older, they're sicker, and they have more health care needs. So we've got to go back and really look at the foundational elements of the ACA. And I think what Donald Trump said about looking at it more cautiously is what the Republicans, ironically, had been talking about in the House. You know, the campaign slogan was repeal and replace, and there were the elements that they were talking about replacing with are things that he's talking about maintaining as well. The limitations on pre-existing condition, no underwriting, allowing 26-year-old adult children to stay on their parents' policies, expansion of Medicaid. I don't think we're going to see going back and taking away Medicaid from the people who have gotten it here. We may see a different way of delivering it, but I don't think America is going to take away coverage from the 20 million people who've gotten it from the expansion of Medicaid.
So where are the insurance companies, who seem to be the big lobbyists the first time, as well as now. Where are they on this issue?
Well, what I've read is I think they see that there are fundamentals that need to be fixed as well. I think one of the things that's different now, and it's certainly how we are approaching this, is we have to collaborate with all the sectors of the healthcare industry, which is a big part, as you know, of our economy. We have to collaborate with them and say, how do we make this work in cooperation with the government? It's not going to be about market share for insurers, market share for providers. It's going to be how do we actually do this in a sustainable way that our economy can afford and patients can get the care they need. I think we have to really step back and learn from our mistakes.
How does this get accomplished? Because you are correct, but the insurance companies are, as fast as they can, backing out of Obamacare, which is creating a crisis for Obamacare.
Right.
And raising costs for the people who have to buy single programs of insurance with big deductibles and huge premiums that they cannot afford. How do you do this?
Well,
how would you do this?
I think, and no crystal ball here, but I believe that you have to have a short-term approach to help the people who are really suffering today. People in our neighborhood who look at 66% increase in their individual insurance premiums. That's just unacceptable. People who in the Twin Cities are in the middle of cancer treatment at Mayo Clinic on an individual insurance policy, and now they can't even get a policy that allows them access to Mayo Clinic to continue their cancer treatment or other devastating illness treatment. So we need a short-term fix for that, which in Minnesota I think the legislature will address. They'll debate a little bit about what's the proper way to address it, but they've got to fix it now. And then I think we have to take a longer-term approach, which will be led, I think, by the federal government and the Congress. And I believe, this is just my own instincts, but I think we will see more dialogue, more deal-making, if you will, in Washington than we've seen previously. I think Donald Trump's appointment of Mr. Priebus to be Chief of Staff is very encouraging. I think he understands how the Republicans think, but he understands the need to maintain discipline, but also move forward and get policies done that will really help the American people, and especially the American people who voted for Donald Trump because they're concerned about the economy.
Is there any regulatory opportunity here with the insurance companies that say you cannot make someone change a treatment that's already in progress, or a provider of a treatment that's already in progress? Is there a regulatory piece?
We've looked into that. We don't see a regulatory approach now, but what we're doing is we're going to work very closely with the insurers to make sure that patients' needs are met. And it will require us really talking with the insurer and the patient to try to make that happen. Especially in cases where Mayo Clinic is the only place in the state that can provide the kind of treatment they were getting. And in that situation where Mayo is uniquely able, the only place in the state to provide that treatment, we're going to have to really work hard with the insurers to make sure that that patient continues to have access.
The insurers contend that they're not making as much money by the current system, and that's why they're backing out. How do you talk to them?
Well, I think it's fair for them when they say, or accurate when they say they're not making money, because I go back to how we determined the fundamentals of the insurance. If you're measuring risk for a smaller, sicker, older population on the same way you're measuring it on the way you do the risk at Mayo Clinic for our employees, or General Mills or Target, there's a bigger group to spread the risk, healthier, younger. It's apples to oranges. So they're clearly going to lose money paying these rates for the sicker people. So that has to be fixed. It's not headline grabbing. It's not naturally, intellectually stimulating, but it's critical. The fundamentals of insurance are critical here, and I think that's what was gotten wrong, and it has to be fixed.
I keep wondering if small groups of people couldn't form a self-insured operation. But there must be some law against it, or you'd have every church and every school doing self-insurance and modest costs.
Well, self-insurance is a risky enterprise. You have to have enough reserves to cover catastrophic events, which in a small group, if you get one person who's very seriously ill, it could bankrupt a small group. So there are rules around the amount of capital and the skills that you need to manage the risk for groups. And so I think there are limits, and small groups know, okay, we can take on this risk of catastrophic event, or we can't. And so there are some pretty significant regulatory rules around doing that, which I think in a way protect groups from taking on too much risk, not being able to cover the cost of the care, and maybe bankrupting the group. So there has to be a lot of intelligent due diligence going into assessing whether or not a group should self-insure.
All right, everyone I think has an idea what the president should do. You get all these suggestions about moving everybody at 55 to, say, Medicare, making that age a little bit younger. And then they have all kinds of proposals for the president to deal with the rest. But it's hard to deal with a budget debt and deficit at the same time that you're trying to do this problem. And a lot of people said in the beginning that Obamacare was just a step on the way to single payer. Do you believe that?
I can't believe that. That is, to me personally, such a cynical view of government. And I was in government for so long, and I'm kind of, maybe some will say I'm naive, but I have to believe in people, they have the best interest of people. So I think we're seeing the demise of a lot of it because the fundamentals weren't right. But I have to believe, because I so truly believe in our system, that it was not intentional. And we can now surgically repair this significant piece of legislation.
So you're not in a blanket repeal mode?
I don't think anybody is in a blanket repeal mode anymore. Because even those who wanted to repeal, it was and replace. Because they know there are certain critical elements of that piece of legislation, that statute, that have to be in place, that have to continue. It's the how it's done is what matters. So repeal, repair, and replace. That's what we prefer.
Okay, so what would you repeal?
Would certainly repeal some of the way that, and I don't want to sound like an insurance expert because I'm not, but I think we have to go back to the basics and say, this is a huge insurance program. And unless the fundamentals of insurance are really right, everything cascades negatively, and that's what we've seen. So I say we have to go back to, in the deep, deep pages of the ACA and say, how do we measure risk? How do we evaluate it? How do we calculate it so that it actually truly measures the risk, which we now know of people in individual insurance? And I do think that there may be an opportunity to give states more ability to be creative. There was more limitations on the creativity, and I think that may happen. I think we'll also see more movement towards consumerism, more engagement of consumers in their healthcare choices in finding healthcare information. So we would like to see that continue, but we definitely want to repair the parts that are critically broken. I don't think we want to see a radical change in Medicare. I mean, right now, the cuts were very significant, and the movement, Jane, in Medicare towards paying for value, paying for quality and efficiency and outcomes, rather than just paying for how many tests you do, is really good. It's so hard to figure it out and get it right. And like the ACA, you have to have the fundamentals right. But we want to see that continue too. So we're going to actually be advocating for continued movement towards value in healthcare, in Medicare, in Medicaid, and even in commercial insurance.
Would you oppose lowering the Medicare age to 55?
We would have serious concerns about that. The Medicare program, while it is very, very popular, it's facing solvency issues. It's facing real solvency issues. And back when it was promoted, there was a real concern whether employers, especially large employers, were going to stay in the health insurance business and provide health insurance to their employees. They're now clear they're going to do it, especially if we repeal the Cadillac tax. So we would have real concerns about lowering the age to 55, because that is moving more and more towards a single payer system. When we have a public-private partnership, that increases the public side a lot more and reduces the private side. So we would want to see Medicare stay where it is and continue to do some reforms within Medicare as it exists now.
Would you do something with the penalty? Because that seems to be a huge reason why the pool doesn't attract more people, because they'd rather pay the penalty, which is small compared to the premium.
I think that goes back to how do you do the fundamentals of the insurance? And Mayo's never taken a position on the mandates of that, but we certainly think that it's good for people to have insurance, but we've never really opined on whether it should be a mandate on individuals and the size or the scope of the penalty. But we do think people need to take care of themselves, we want to put emphasis on wellness and prevention of illness, and then be prepared for what, if and when you might need health care.
Wow, there's so much to it.
It really is. It's so intertwined. And I've heard Dr. Noseworthy say it's like the human body. Everything relates to, one organ relates to the other. It's not this separate, and we certainly can't look for simple solutions to these complex problems. This is not going to be solved with a bumper sticker. This is going to be solved with a lot of deep thinking and analysis and collaboration of many different industries and the public sector and the private sector.
And if they let the states be more innovative, what would you have Minnesota do?
That's probably a tougher question than the federal government. It is a very tough question, because one of the sad ironies here is that Minnesota's system was working well before Obamacare, from what I understand. It was working well. The risk pool was good. MNsure was, people had health insurance.
Yeah. And we had MCHA.
Yeah,
for
MCHA, that's
comprehensive.
Yes.
For the people who couldn't get the regular.
And so maybe there's some lessons, and we're going to take some of those lessons actually from pre-Obamacare Minnesota to Washington, D.C. as they look to reform the ACA, because it did work here, and people were not facing, triple, quadruple premium increases with skyrocketing deductibles and copays. So we may take some of the lessons from a few years ago to Washington, and maybe Minnesota needs to reflect on why were they more successful before this and act accordingly.
Well, I would think they would if they want. So how would you start with that? Let's say that Minnesota lays out what we did well and why it went well, and we want a chance to do that again for our people. Where do you start? The transition team, or the Congress, or the House, or the Senate, or what?
Well, I think you have to start both places. I think you have to start both places, which is what we're doing right now. We're talking to people inside DC about what was right here and what we see the problems are and what's really emerged as a part of Obamacare in terms of really critically ill patients. Those patients have been lost. Their voice has been lost because they have not had access, more and more restricted accesses to places like Mayo Clinic, Cleveland Clinic, Johns Hopkins, the academic medical centers of excellence across our country. They're getting restricted out of the networks of care. We're very, very concerned about that. That's happening here in Minnesota. So we are taking that message to our legislators in Minnesota, as well as our legislators at the federal level and the transition team.
How are they being restricted out of the networks of care?
Okay. When the insurance company, when you want to go and buy a plan, you'll say, okay, this plan costs X dollars for the premium, Y dollars for the deductibles, and it tells you what physicians or providers, hospitals you can go to for your care. Outside of our region here in southeastern Minnesota, people who live in the Twin Cities cannot go on MNsure and buy a health insurance plan, individual plan on MNsure that provides them access, in-network access to Mayo Clinic. So think of that. People who have cancer now, who are getting treated here today with individual insurance covering their cost, can no longer go buy a plan that allows them access here. We have to make sure that academic medical centers, places like Mayo, are included. So that has been a key message. We're working with insurers. We're educating the legislators and the governor's office about this problem. It's an unintended consequence of the high costs, the bad risk adjustment, the bad risk calculation that has resulted in saying, okay, when they said you can keep your doctor, well, now you can't keep your doctor. And I think that's what we'll see the Congress dealing with. How do we create a system we can afford that gives people the choice they need and access to the kind of care they need when they become very sick?
And does that relate to the people who say we should be able to buy insurance across state lines? We should be able to get our treatment across state lines?
I don't know if it's so much relates directly to that, but indirectly. People who advocate for buying insurance across state lines are really interested in driving more competition. They believe that if you have more competition in the insurance marketplace, people will fight on and compete on price, quality, the size of the network. In Minnesota, we have a very small base of insurance companies, very, very small. So some people say maybe we would be better served if we had more people competing, more insurance companies competing and being attractive to the consumer.
Well, that makes sense, doesn't it?
I think on a basic economic perspective, it makes sense. Then you come down to, okay, who regulates those insurance companies? Is it the federal government? Is it state government? So you start to peel that onion back, and it's pretty complex. But on the face, absolutely makes sense. Competition drives greater consumer choice, and in many cases, reduction of cost.
If you were regulating that process, where would you do it? At the federal level, or in, say, Minnesota, South Dakota, Wisconsin, Iowa, have the separate states all regulated, or what?
Well, that's going to be the challenge. Who owns, so to speak, that regulatory authority? And I think it's going to be one of the complexities of doing that. When you look at the regulation of insurance for large employers, they're guided under this law called ERISA, which allows them to have, ERISA regulates these companies delivering their insurance to their employees.
Are these self-insured?
They're self-insured, and they're guided by ERISA, and they don't have to, they deal with the regulations of ERISA and the Federal Department of Labor. They do not deal with the regulations of, very simplistically speaking, each state in which they live. So going across state lines may require more federalization of insurance, but we will have to see. I think it's a very, it's something that I know has been promoted by Republicans for 20 years, but it's never really been passed and tested and thought out further than the statement of increasing competition.
If there were no Obamacare, move the calendar back, what would people do?
I think it's hard to imagine. I think we probably would not have had the expansion of Medicaid that we've had. We probably would have had more higher cost in some regards because of greater use of emergency rooms for primary care, greater amounts of uncompensated care for hospitals. And I think the promise of Obamacare was one that was I don't think anyone could criticize the promise of it. It's the execution of it. And we need to continue to work on making certain that the fundamentals of healthcare are there for all Americans, but it is sustainable in our economy and does not restrict our ability to be globally competitive by hamstringing 17% of our economy.
Is Medicaid a state program? Is that partially funded by the federal government? And if so, what percent?
Medicaid is a program that is funded by both the federal government and the state government. It operates predominantly by federal government rules, and the state government has flexibility in how they enact those rules. So it's a good example of state-federal government, and when it works well, it works really, really well in serving patients' needs. And sometimes there's overlapping regulations and the bureaucracy gets in the way of the patient needs, but for the most part, it works well, and it is a state-federal partnership with some capability for innovation and state experimentation.
And that's what you want to maintain.
Well, I think that is a good approach. People always say our founding fathers said the states are really the experimenters in democracy and in trying things. And here we can't stop trying to innovate in healthcare. We're never going to reach the perfect state. Healthcare is not like that. We'll have to keep innovating. We'll have to keep exploring ways to reduce costs while increasing quality. Those are not antithetical. They're essential. And we have to do that with experimentation, innovation, trial and error, and the states can be a big part of helping to do that.
You have helped us greatly understand the complexity of the issue. Now, for our viewers who are concerned about these issues, what do they do? Just stay calm and watch the progress, or do they write to their congressman, or what do they do?
Well, that's a great question. I think one thing I think especially for Minnesotans to do is to really participate in what happens right now. If you are trying to purchase insurance off of MNsure, and individual insurance or small group insurance, you're facing very steep premium increases. It's critical to have your voice heard by your legislators and your governor and your executive branch that these premiums are not sustainable. Something has to be done in the short term. People need help to make sure they get the coverage that they should have. And then I think continue to engage with both your state legislators and federal legislators.
Kathleen Harrington, we are so lucky to have you
share
a half hour with us, the head of the Policy and Government Relations at the Mayo Clinic, and we wish you lots of luck, and I know you'll be back.
Oh, I hope
when
so.
you can bring us the good news and the bad news and the news we're still working on. Thank
Right.
you.
Thank you, Jane.
Thank you, our viewers, for being with us this week. We'll be with you again next week, same time, same channel. In the meantime, have a very good week and have a very good night.